Why has melanoma just been such a graveyard in drug development over the last year? Why did we not have any drugs before Yervoy and Celbraf? Does this have to do with the lack of biomarkers? No, not really. There were plenty of biomarkers that were identified. There were ILA, there was the interference, there were all kinds of IL-2 stories that were available. But they were really never came to the point where in a personalized setup anything was tested in forming hypotheses for subtypes. It was all looked in a traditional way at melanoma drug development. And many of the things, the targets didn't pan out. We have to understand and appreciate that this is unfortunately the majority. In our business, we many times get frustrated by trying to do all the right things and then to find out, well, it still didn't work. There's something we don't understand yet. I like to come back to B600 BRAF, not just in melanoma, as you know. This mutation is expressed in 8 to 10% of all solid tumors. So people have looking at elsewhere as well. But the only study that we have done this sort of reasonably precise way, turns out the response rates are not the same as in melanoma. There are response rates, but not to the extent seen in melanoma. So even though it's the same marker that is there. So having said that, we still have to learn much more how these biomarkers and best used as targets. And we cannot necessarily extrapolate from one cancer to the other. Now, melanoma has the other downside that it's a disease that is so aggressive, that is so aggressively fast, that it really is a high bar from a development perspective to see any difference. That may be why other cancers that have a longer development timeline before they become fatal have been better from a drug development perspective. It's not that people were not looking for it. There's plenty of markers out there. And as I said before, there will be, for the KIT-driven tumors, will be drugs that were available. There are some in the market already. NRAS is identified as a target. It's a difficult target because we know RAS mutations in other tumors. They have not been able to drug them, although they are recognized as dominant oncogenic drivers. Here, the drug discovery technology is sort of lagging a little bit behind. And I'm sure, if you look more, we will find other subsets. But most importantly, I think, where we now have those BRAF positive tumors, looking at resistance, how resistance comes about, this is where I think I will expect to see the biggest progress. Generally, the capability of generating potential biomarkers over the last few years has gone up exponentially compared to the past, because primarily with the high throughput sequencing and high throughput sequencing getting cheaper and cheaper, lots of academic institutions starting now collecting data. My concern here would be who's sifting through all the data, who's making sense, and then out of the data we need to build hypotheses to ask questions. Well, are these just epiphenomenon? Are these passenger mutations, or are they actually driver mutations? And this is going to be the hard work. And once we have identified driver mutation, if they're druggable, well, we know what to do in terms of drug development. But it's not going to be something that will be changing overnight. I know that some people have this expectation with sequencing, the field will be changed in 2 years. I like to manage expectations that from the time you have identified a potential target to having something on the market is still many years away, unfortunately. It will change, and we have shown that with a companion diagnostic, and we're building this hypothesis in a more better defined way, we can accelerate the drug development process quite substantially, but still it will be numbers of years before we see the benefit of these new technologies coming through the bottom line.